biomechanics is a fantastic one. I appreciate a lot your examples about the bolts and other things that you use to explain for us the ligaments and the shoulder muscle stabilization for the shoulder. Good evening, everyone. Again, I am Mauricio Raffaelli from Sao Paulo. Can you hear me?
Yeah, we can hear you.
I am Mauricio Raffaelli from Sao Paulo, Brazil. I would like to say thank you for this inviting me to participate in a spectacular event, showing that the pandemic can indeed bring together various places inside the computer when you want to grow in our knowledge. I'm very proud to participate in this event. I make part for the NAEON Institute from Sao Paulo, Brazil, led by Dr. José Carlos Garcia. And this group make part of Brazilian Shoulder and Elbow Surgery Society, led by Dr. Roberto Ikemoto. It's our manship society from Brazil. This is my disclaimer, where I don't have any conflicts of interest in this presentation. And just like Dr. Amr, I would like to talk a little about anatomic. So to understand the subscapular lesion, I would like to have a brief review of the anatomy of the subscapularis. The subscapularis origin is from anterior surface of the scapula, and its insertion is in the last tuberosity of the humerus, has blood supply through the subscapular artery, and innervation of the upper and the lower part of the subscapular nerve. One another important things to understand the anatomic and to understand the repair of the subscapularis lesion in the planning your surgery is the insertion of the subscapular in your footprint. This insertion has a trapezoidal shape with its upper parts wider than its lower part. And remembering that the lower third presents a muscular insertion only, not a tendon insertion. The anterior function, the subscapular has important functions in shoulder mobility with internal rotation function, and has important function in stabilizing the shoulder, being the anterior dynamic stabilizer of the shoulder and participate the balance of the straight force and stabilizes the long head of the biceps too. The balance force of the shoulder have antagonists the subscapularis anteriorly and infraspinatus and teres minors posteriorly, showing the great importance of the subscapularis tendon in the shoulder function. Just Dr. Amr just showed it for us. Smith was the first to describe the subscapularis lesion in 1835. Frankel and Caulfield demonstrated the presence of 80% of subscapularis tears of all shoulder cuff injuries, rotator cuff injuries. Dr. Geber showed the association between the subscapularis and supraspinatus tears, and Dr. Warner showed that the presence of the lesions of subscapularis can pass concealed in some cases. This caused the subscapularis tendon have been known as a forgotten tendon for a while. Show here a patient already operated for injury to the subscapularis tears and maintained an injury to the subscapularis tear. The injury mechanism found in the subscapularis is traumatic and degenerative. The traumatic being related to reprostection and external rotation, and the degenerative may be related to the pathology of the cuff, which is more common and may be related to the impact of the coracoid too. Usually, pain, increase of external rotation, and loss of internal rotation straight are complaints found in subscapular tears. And tests such as lift-off, Napoleon, belly press test, and beer hug test can help us in the diagnosis of these injuries. This article showed that all of these tests have sensitivity in the diagnosis of complete lesions of the subscapularis. However, the association of these tests increase the sensitivity of diagnosis of the partial lesions of the subscapularis. The main exam for diagnosing lesions of the subscapularis is the magnetic resonance image, or MRI, showing that in the axillary section we can see tendon injuries directly, as in this case, and indirect signs such as anterior dislocation of the long head of the biceps are in this other case, this one, this other one, and this one. And we also can see in sagittal cut of the MRI, partial or total subscapularis muscular atrophy, like in this case. This article showed that the MRI sensitivity can be low to diagnose the subscapularis tears, but with high specificity, which means that we should always look for lesions of the subscapularis in our shoulder arthroscopies. Pifferman brought this classification of subscapular injuries in 1999. Fox and Romeo modified the division of these injuries in 2003. And Dr. Lafosse complements this classification with the retraction of the subscapularis associated with loss or anterior stabilization. Surgical treatment of subscapularis tears can be performed in an open manner, with the surgeons still preferring the deltopectoral approach. However, the better anatomic understanding and the evolution of arthroscopy surgery put this form of surgery with importance in the repair of the lesion of the subscapularis. We can use scopes of 30 or 7 degrees. I prefer to use the 30 degrees scope, and I use the beach chair as the patient's position. And the important thing in this arthroscopy surgery is to perform the posterior lever push with an internal rotation of the arm, abduction of the arm, and create a little traction for the humerus for posterior traction to improve the view. Look to this case. If you have only rotation, you cannot see the subscapularis tears. And when you do the posterior lever push, you can see perfectly a lesion in this case. In articular arthroscopy repairs of the subscapularis tears, I usually maintain my scope through the posterior portal and perform the anterior portal, normally use it for placing the anchors and passing my sutures. And I perform an anterior lateral portal to manipulate the tendon and observe the repair performed and possibility to do a coracoplasty. And when it presents an important lesion of the subscapularis, I usually put my scopes through the lateral portal for a subacromial approach of the subscapularis tendon. Very often, the tendon of the long head of the biceps is involved in the lesion of the subscapularis and must be treated together with the tenodesis or tenotomy, and must evaluate the quality of the tendon to decide the best procedure and place to perform the tenodesis. This article showed better results in the repair of the subscapularis tears when the treatment of the pathology of the long head of the biceps is involved concurrently. In 2003, Dr. Burkhardt presented us with the coma sign, which is a highly resistant structure that assists in the diagnosis of the subscapularis lesion and aids in the tendon manipulation. This region, this coma sign, is formed in the medial part of the joint, the junction of the superior glenohumeral and coracohumeral ligament. In 1985, Dr. Gabbard showed us the importance of the subcoracoid impact on the subscapularis tears. And in 1987, he studied through tomography to normal subacoracoid space ranging from 6.8 to 80.7 millimeters. But Dr. Burkhardt, in 2003, described the arthroscopic coracoplasty to be performed in supracoracoid space less or equal than 6 millimeters. However, more recent studies showed that coracoplasty must be studied and performed in each case, and it's not a routine for all subscapularis tear repairs. And another important factor to do a great repair of the subscapularis tears is the realization of the anterior and posterior release to repair the tendon with less tension possible. Now I will show some cases to explain my techniques of the subscapularis repairs. Here we have one patient with 41 years old, male. He used wheelchair because of a paraplegia after an automobile accident 21 years ago. But now he is a paraplegic, a parathlete basketball player. He had an anterior right shoulder pain after a block during a basketball game, and he just had a chronically long head of the biceps lesion 6 years ago in the same arm. The test was near test negative, Hawkins test negative, Job negative, Palmer test negative, but all tests for subscapularis tear was positive, like belly press, bear hug, and lift off. And the Popeye sign is positive in this patient too. There is no change of radiographic in this patient. However, we observed signs of the injury to the upper part of the subscapularis. You can see the atrophy in the upper part of the muscular subscapularis and the small tears in the upper part. And you can see the long head of the biceps in your groove because it's just have a lesion of that. So this is my surgery. I am with my 30-degree scope for the posterior portal. You can see the lesion for the subscapularis, the upper part of the subscapularis. I think that we need to see the passage sutures, and you need to see your subscapular tendon to do a good repair. So I start to create the anterior portal and clean all the rotator interval to have a good passage for my suture, and I don't want to involve in my suture the medial and the superior glenohumeral ligaments. With the anterior portal, I start to clean all the rotator curve interval, stop the blood because blood will we can't see very good with this blood. I'm putting the anterior cannula, and in this cannula, I will pass the sutures, I will put the anchor too. Through this cannula and maintain the intended rotation of the shoulder, I will debride this lesion and will create a better footprint, cleaning the bone and create a good blood supply to improve my tendon healing. So I prepare a good footprint. I think it's very important to create a good healing. You can see my footprint with some blood. That's a good place to put my anchor and to do my suture. In this case, I used regular anchors to 4.5 millimeters, absorbable one. So I create the hole first, and after that, I will put my anchor. Here is performing the hole. And now I put my regular anchor through the anterior portal through the cannula. After that, I would like to put my sutures out from the cannula because I would like to pass through the tendon first. So I will create another anterior lateral portal to put my sutures out from my cannula. Here, my portal is done, and I will take out the sutures from the cannula. And using the same anterior portal through the cannula, I use it a suture passer like a bird beak to pass the sutures through the tendon. In this part of the surgery, it's a little bit difficult to recover the sutures because the sutures is being the upper part of the joint. So put the sutures inside the joint first to make this phase a little bit easier. I pass the lower suture first, then I use the same suture passer in the upper part of the tendon, and I will recover the other suture. Yes, I did it. And now I start to tighten my knots. I do love to do the upper knot because I will improve the approach of the subscapular tendon, and then I tighten my lower suture to improve the lower part of the subscapularis repair. And in the end of the sutures, that's the result of my subscapularis repair. I think we have a good approach of the footprint and a very good tendon next to the bone. This is one all-articular repair of partial lesions for the subscapularis. The next case is a patient with 53 years old, male manual worker for 26 years. He reports pain in his right shoulder 7 months ago. It's becoming worse and worse every day with worst pain with the mobility and in the daily base work. This patient has tested positive for supraspinatus and subscapularis tendons. Near positive, Hawkins positive, Joby test positive with loss of straight when you compare to the other shoulder. Gerber test positive, beer hug test positive, palm up is negative, infraspinatus test was negative, but this patient has normal range of motion. And this is this patient exams. You cannot see some difference in the X-ray, but you can see a big lesion for the supraspinatus and a retraction lesion for the subscapularis too. And this is the surgery for this patient. I maintain the beach chair position. You can see the long head of the biceps and a big lesion for supraspinatus too. And you can see the subscapularis very well. So I pass a suture to the biceps to make his stenotomy. The biceps is in my hand with the suture, and I perform the tenotomy through the rotator cuff lesion, to the supraspinatus lesion. And I will start to clean the rotator interval. Here you see the coma sign. Here's the coma sign. It's a very big structure. I start to clean the rotator interval, and I pass a suture through the subscapularis to improve my mobility of this tendon. I begin to clean all the anterior part of the subscapularis to release and to maintain this tendon with mobility. You can see here the base of the coracoid. So I release all anterior part of the subscapularis and try to improve the posterior part of the subscapularis, cleaning the capsule to improve the manipulation of the subscapularis tendon. You can see I can manipulate to the lateral of the subscapularis tendon, cleaning medial, anterior and posterior of the subscapular tendon. Now I am in the subscapularis view. My scope is for a posterolateral portal. I am creating the footprint for subscapularis, and I test the mobility of the subscapularis to see if the tendon came to the footprint. And yes, the tendon come to the footprint. And now I will pass one suture In this case, I use 2 sutures to do the subscapularis repair. I use regular anchors too, for 5.0 millimeters regular anchor, bioabsorbed anchor with 2 sutures. And looking for the subscapular approach, I will perform a subscapular repair just I made a supraspinatus repair. So I pass the sutures, the first suture in the lower part of the subscapularis. I recover the suture, and then I will take the other part of the same suture and I will pass a mattress way of the same suture. And then I go into this one and I performed a Mason Allen suture that I believe that I can improve a better quality of my repair. I tied the knots of the mattress part, and after that, I tied the knots of the regular suture. And that is my upper suture just done. And this is my subscapularis repair. And here's the finish of my surgery. I did a double row for the supraspinatus tendon, and I performed a Mason Allen repair for the subscapularis. In the end of the surgery, I go a little bit higher to the biceps tendon, and I performed a tenodesis, a subpectoral tenodesis of the long head of the biceps. In 2002, Dr. Burkhardt showed excellent results in the arthroscopic repair of the subscapularis tears, and he complemented this study in 2008 with a minimum follow-up of 5 years, maintaining excellent results for this study, this surgery, arthroscopy surgery. Other studies showed that open and arthroscopic repair have similar results. And arthroscopy repair becomes a reality in the positive results in the supraspinatus, subscapularis tear treatment. In conclusion, always look for the lesion, and please, comma sign can help you to find where is the tendon is. Plan your repair, always plan your repair. Stay prepared to find a subscapularis tear in all arthroscopies. Retraction tendons, please do the release to test the tendon mobility before to do this repair, and looks for the subacromial space and do the corticoplasty if necessary. And to recover the shoulder biomechanics, always try to repair the subscapularis tendon. I would like to invite all my friends for our international course that we will make in 22nd to 24th of October of this year. This is a partnership through NAEON Institute from Dr. José Carlos and Alpes Institute from Dr. Laurent Lafosse. And I hope to see everyone there. And this is my group. I just want to say thank you again for this invite. And I'm here for all questions and all discussion. Thanks a lot.
Thank you so much, Dr. Raffaelli, for your interesting and fantastic talk about the subscapularis pathology and the subscapularis repair of the tears. May we start discussion? My first question to you, Dr. Raffaelli, what's the difference in your technique between the acute and chronic subscapularis tear?
I think the difference to acute to chronic, you can see about the atrophy of the muscle. If you have a lot of muscle atrophy, you can see that's a chronic one. The books, the paper said for us that if you have a lesion through 3 months, you can maintain this lesion like acute. And if you have more than 3 months, it's a chronic. But I don't think that's this number, 3 months, is right to make this divide of a chronic one or acute one. I just want to see the quality of the muscle. If you maintain a good quality of the muscle and a good mobility of this tendon during the surgery, I think that you can consider this acute one. And if you have a poor quality of the muscle and a good retraction, I really think that's a chronic one.
Yeah. Another question from Dr. Ahmed Mari. What's the rotator interval?
The rotator interval is a space that we have formed by a triangle. You have the subscapularis, the lower part, long head of the biceps or a superior glenohumeral ligament, and the glenoid. This position, you don't have any good structure, and you can open this part to go through the articulation.
Another question from Dr. Hisham. In case of subscapularis repair, when and how can we start the physiotherapy?
I don't want to do a fast recover, a fast physiotherapy for this patient. I usually maintain my patients 4 weeks, usually a sling, normally abduction and external rotation sling, because I don't want to lose some range of motion of my patients. So I maintain 4 weeks my patient with a sling, and after that, I become the physiotherapy.
Yeah, thank you. Another question from Dr. Ahmed Al-Imam. When to do pectoralis major transfer in subscapularis injury?
This is a surgery that I don't do usually. We have some discussion for what's the best tendon to do this transfer. Now we have the pector major. We have some papers showed for the pector minor, and now Dr. Bassem El-Hassan was showed for us a latissimus dorsi transfer for subscapularis tears too. I think that if I want to recover the mobility and the cinematic of the shoulder, I need to improve the the anterior stabilization of my shoulder. So if you can't do the suture of the subscapularis, or if you have a trophy grade 3 or 4, you need to use another tendon to do this job. So in this way, I will part to do this transfer.
Yeah, Dr. Bassem El-Hassan was Dr. Bassem El-Hassan was supposed to be with us in this review course, but unfortunately, he's in overseas conference nowadays.
Yeah.
He apologized to me just yesterday.
Dr. Bassem El-Hassan is a fantastic guy. He's a very good friend. Yeah. I just stayed with him in Mayo Clinic. And Dr. Bassem El-Hassan just stayed with us in NAEON Institute in our course in 2018. He's a fantastic
I think he's in Harvard now.
Yeah.
He's in Harvard after he's have been in the Mayo Clinic. Yeah.
Yes.
Another question for you, sir.
Changed.
Yeah. What's the difference between open and arthroscopic repair? I think you have mentioned it in many papers.
The open repair is when you do the approach of the subscapularis stairs, doing a deltopectoral approach, and you can you can repair using a transosseous suture, or you can repair this using anchors too. An arthroscopic way, when you use a scope to go inside for the articulation and do it most closely than you can, using small portal, and you can do this repair using anchors in this way.
Another question from Dr. Gregors Maloba. When you have a proximal humeral fracture with displacement associated with humeral ligament rupture, how can you interfere with this?
I think the part, this important part is to have two pathologies, two diseases. The ligaments injury and the bone injury. Yes. In the first part of the treatment, I will treat the bone injury, and I am going to wait if this patient has some instability of the shoulder, and I will approach this instability after that. So I perform the fixation of the bone fracture. And after that, I will looking for instability, and then I will fix that if the patient has one.
The last question I see from Dr. Ahmed Suleiman: how to pass a stitch in the cut tendon to tight the anchor?
Sorry, I don't understand. Sorry.
How to pass a stitch in the cut tendon to tight to anchor?
How can I pass my sutures?
Yeah, suture stitch.
My suture stitch, normally I use 2 types of instruments. I use a bird beak one to pass the sutures, and I use the some another stuff like a scorpion disease or a first pass suture passer that I can use because it's a little bit easier to use that. And to tighten my knots, I only use regular sutures or normal sutures. I don't like to use slide sutures. I use slide knots. I use a regular knots to do that.
Yeah. This was the last question. Thank you so much, our beloved professors, Dr. Amr Ashwan and Dr. Mauricio Raffaelli, for your interesting talks. It was a very nice night. For you, Raffaelli, it's very nice afternoon.
Yes,
Take care of the brain outside. Nice to meet you.
The end of my day.
For a wonderful presentation.
It was a wonderful presentation. Yeah, of course. Thank you so much.
Dr. Amr, I really appreciate your presentation. I think that you can review the biomechanics of the shoulder in a couple of minutes. I think it was perfect. Thanks a lot for your presentation too, and thanks for the opportunity to stay with you in this meeting.
Thank you so much.
Thank you so much.
Thank you so much. Have a nice night and have a nice time, and take care of the rain outside.
Thanks a lot.
Thank you so much. Shukran, Dr. Amr. Thank you so much.